Thank you, Prof. Good afternoon, everybody. My name is Ernest Ace. Giving a presentation on breaking bad news with my colleague, Dr. Sarah Ford. We're both located in the Barrow Circuit at Mafolo CHC. So to start off with, the main question is, what is bad news exactly? So bad news is typically any information that is expected to alter a person's life in any way. This is a very reductionist view on what bad news may be, as bad news can range from anything from severe to giving a patient a diagnosis of terminal breast cancer, as well, or to telling someone that their car has been stolen or that their phone is no longer working, something like that. But typically in our setting, bad news is typically dealing with situations in where you're giving people bad news relating to how their bodies are working. To start off with, we're going to speak about a video of an example of how bad news should not be broken to a patient. So just have a listen.
The doctor's not come yet. Yeah. I don't know. Oh, the sister's here. I'll call you back. Sister? Have the results come in?
Yeah.
And how is he?
The doctor needs to come.
But just tell me the number. I'll understand.
I told you, no? The doctor has to come.
Why? Is there a problem?
Bad news?
No. You just relax. Please tell me, sister. What's the problem? Oh, hello, doctor. I was just trying to get the nurse to share the results. Is it bad?
She's not supposed to tell you good or bad.
But
okay.
She didn't say that, right? You didn't tell me that. So?
Yeah, the results have come. 328.
And? What does that mean?
Just one sec. Hello. Hi Deepak, how are you?
So, the results?
We have to take serious action now. Otherwise...
Doctor, can we talk outside?
Oh yeah, why not? Come.
So, as you can see, that was a pretty bad example of how one should break bad news to a patient or even a patient's family. So essentially, the main issue for breaking bad news is it's actually quite a difficult skill for doctors or any healthcare practitioner to master. So important things to look at is why is it's so difficult to do. So typically, the majority of us on this meeting are junior doctors, so we have a lack of experience in how to do this. We often leave it up to our more senior registrars or consultants to do, as they often have more experience to do this. But it is something that we need to develop over as our career continues. What also is very important to remember is that no patient is actually the same. Each patient has an entire biopsychosocial environment which is entirely different. So a patient's diagnosis is different from the next patient, even though they may have a similar disease, mainly because their psychological influences that they may have. A patient may be ready for treatment, some patients may not. Other patients may also have a good support structure, while some may not have an adequate support structure. These are all important things to consider when going to break bad news to a patient. Also, as I said before, not all bad news is the same. Giving a diagnosis of cancer versus being telling someone that their car has been stolen are two different things. As doctors, we may have a feeling of sense of failure towards our patients. We often try to do the best, and also giving them a terminal diagnosis or like diagnosing someone with CKD often feels that we haven't done the best that we could have at that time. Also, what some people may find difficult is a feeling of being unable to deal with a sudden outburst of emotional distress, as some patients may react to when they've been told that their loved one has passed on. Another thing is also angry family members. Angry family members also make it very difficult for us to break bad news because they often shout at you and ask you, why could you not have done more, when all you could have done was what you're limited to do. And what is also probably most profound for some people is awkward silences. Often you stand there waiting for someone to say something and you feel that you need to butt in and give them reassurance, but this is not always the case. So why is breaking bad news so important? So first and foremost, it helps maintain a good relationship with the patient if it's done correctly. If done incorrectly, a patient will have a sense of distrust towards you. But when done correctly, the patient will have trust within you, and going forward, you'll be able to set realistic treatment goals to better a patient's care. Often patients go for months on end without knowing exactly what's the cause of their condition. So they have all these symptoms and they're feeling quite poorly and they have no formal diagnosis. So when you break the bad news, it helps alleviate some of that uncertainty and gives them some sort of comfort knowing that, okay, there is something wrong with me. I can move on, and hopefully there's more hope going forward. And additionally, it allows a patient time to adjust to their diagnosis. So before setting the realistic treatment goals, they can come to terms with their diagnosis. So important aspects relating to breaking bad news. As I said, it is a skill, and there are several subset skills that one needs to master. So ideally, when you break bad news, you need to involve members of the family and/or close friends. A good support structure is always necessary when giving the bad news, as well as setting treatment goals going forward. It's also important to remember that silence isn't always a bad thing. You need to let a patient speak when they need to speak. And if there is a silence, don't butt in. Just let it progress organically. Good communication skills are also important. I'll touch on that in the next slide. As well as the most important thing to remember is that the patient is the most important part of the entire process. Maintaining empathy and sympathy are also important, and to maintain an aspect of hope, but within reason, not to give a patient false hopes and saying that there is a miracle cure that they can partake in when they have a terminal diagnosis. And also lastly, to create a stepping stone into the next phase, this being allowing them to get their affairs in order or to come to terms with how to progress in terms of treatment. So as I mentioned before, communication skills are an important aspect. There are a number of subset skills and communication skills, but I have highlighted two of the most important ones that the patient experiences, that being actively listening to the patient and being mindful of your own body language. So when it comes to actively listening, you want to pay attention to a patient's concerns while keeping quiet and summarizing the patient's points when they've finished talking. And being mindful of your body language means to nod your head in agreement, have an open arms, as well as maintain eye contact. These all imbue the impression that the patient is, that you are listening to the patient, and that they will develop greater trust in you, knowing that what they are saying is being heard. So things to avoid when breaking bad news. So the number one thing is not to devalue a patient's feelings. So an example would be, so it's quite a common cancer, Mrs. Smith. This may be true for epidemiological purposes, but for Mrs. Smith, it is actually quite a bullet to the heart, so to speak. She may feel that, oh no, the doctor doesn't actually care. It's quite a common cancer for him to treat. He sees it all the time, but it's still happening to Mrs. Smith. If you're telling a patient to look on the bright side, no patient will look on the bright side. If you have a terminal diagnosis, it's not going to help. But if you have CKD, it obviously has an endpoint. You should never tell a patient it's going to be okay. It may be okay in the end, but during that time, it's not going to be okay. A patient may actually suffer quite greatly. And lastly, omitting information that can change a patient's mind. Every patient has the right to all the information they want to know about their condition. There's being various treatment options. If it's an aggressive treatment that could kill them in the end, or if it's an aggressive treatment that could save their life, versus more palliative care, that if they opt for palliation instead of aggressive treatment, that should be their option to decide on. So there are a few different approaches. I've highlighted the three main ones that I've seen in my experience working as a doctor. The first is what is known as the velvet hand grenade approach. So the doctor often beats around the bush until the patient actually asks that burning question, and then you give them the answer. Another is a hit and run approach, which is an example that I've noticed last year during my internal medicine rotation. And the other is a direct approach, which is often we're guilty of as interns. Most older patients often ask, is this what it is, doctor? And we just say yes, out of a lack of experience in how to deal with this. And the last one is a spikes approach, which has become quite popular over the years and actually deals with quite dealing with breaking bad news quite well.
Okay, so as Ernest has just mentioned, one of the approaches that we can use to break bad news is called the spikes method. The spikes method was first published in the year 2000 in an article by Robert Buckman. It was created as a simple 6-step process for oncologists to communicate the diagnosis of cancer to their patients. So, okay, I can't control the screen. Please, thank you. The 6 steps are basically set out in the SPIKES acronym. They are setting, perception, invitation or information, knowledge, empathy, and then to summarize or strategize. And we'll now look at each of the steps individually. So the first step is getting started. So this is the most important step. When breaking bad news to a patient, you need to be in the right setting. Ensure a quiet, private space to prevent interruption and have the patient seated comfortably. Be prepared for what you're about to tell the patient, their reactions and their questions that might follow. Ask the patient who they would like in the room with them during this time. Try to build a rapport with the patient before delivering the bad news. To do this, introduce yourself and use the patient's name to make this more of a personal interaction. Introduce this as more of an opportunity to understand the patient's condition and set out goals for their further treatment rather than as a bad news setting. The next one is perception. How much does the patient already know? Before delivering the bad news, ask the patient what they understand about their condition, what is currently going on, and what tests have been done. Make sure to use open-ended questions to allow the patient to express their knowledge fully. It's important to listen to the vocabulary that the patient uses, as this will help you to deliver the news at an appropriate level to the patient so that they can understand. The next one is I, invitation. How much does the patient actually want to know? Ask the patient how much they want to know right now. Give the patient the opportunity to stop you whenever they feel they've reached their limit of information for one setting. This prevents the process from going into an uncomfortable territory. This is, however, unlikely, and it's something you need to be aware of. This prevents the process from becoming uncomfortable. It's important to watch for non-verbal cues of when the patient has reached their limit. Watch out while speaking to the patient for signs of denial. Respect this as a form of coping and ask the patient how they are feeling about what has been said or what they might be thinking. So then the next step is knowledge, and this is where you share the information. Now that you understand what the patient understands, at what level, and how much they wish to know about their condition, you're able to share the diagnosis with them. The aim of this setting is to narrow the information gap between what the patient did already know and what they now need to know, and reduce any uncertainty that they may currently have. Make sure you use the words the patient used when explaining their situation to you, and reinforce what they have said that is still correct. Try to give a warning shot before delivering the bad news. This helps to warn the patient that something is coming and helps the clinician prepare for how the patient will react. An example could be, you were right when you said that this seems like it's quite serious, or yes, your understanding of the situation is correct. Give the information in small pieces, but be clear. No medical jargon is to be used. And deliver the information at a pace that the patient can keep up with. Always clarify what you've said. Ask the patient if they understand and if you need to repeat anything. You can even make use of pictures or diagrams to better explain what's going on. The most important part of this step is to know when to stop. Look at the patient's verbal and non-verbal responses to decide when the patient has heard enough for one day, as they often won't tell you to stop. The next step is E, empathy. And this is where you respond to the patient's feelings appropriately. Acknowledge what the patient is currently feeling and help them put in words what they are feeling. Stay calm. As we mentioned about the awkward silences, these are to be expected after receiving bad news. They aren't awkward. This is the patient's opportunity to process and understand what you've told them. Let them process. Be empathetic and understand what the patient is feeling. It's okay to cry if the patient cries. Then the next step is to summarize and strategize. When the patient has reached their limit, stop. Summarize what you've said. Make sure the patient understands fully. Help your patient to prioritize the problems in relation to their life. Help the patient to determine what can be fixed from what can't be fixed currently. Identify the coping strategies that they express during the session and help them to identify sources of support they may not have even realized are available to them. Facilitate all questions the patients may have to the best of your ability. Don't be afraid to say you don't know. Review the goals and expectation the patient has in the current situation. Identify their priorities, but try not to shatter the patient's hope. Once the patient has finished asking questions, make another appointment with the patient to follow up in a few days. This shows your patient your commitment to ongoing care and allows the patient and their family time to go home and fully understand what has been said. When they come back, you are then able to introduce the multidisciplinary team that will provide the patient with ongoing care and even introduce the idea of palliative care if appropriate. And those are our 6 steps towards breaking bad news. Now that we understand them, we can re-watch our earlier video where the patient and their family received bad news, this time applying the spikes concept and then watching the news being broken properly.
I don't know. Oh, the sister's here. I'll call you back.
Good morning, ma'am.
Hi.
I'm Nurse Shalini.
Hi. Have the results come yet?
Yes, ma'am. The doctor will have to come and communicate it to you. You'll have to wait until he comes. I'm sorry.
But you must know, right? How is he?
Sorry, we are not allowed to discuss or review the results. You'll have to wait for the doctor. He'll have the expertise to interpret it properly. I know you're worried. I'll ask him to come here first.
Thank you.
Good morning. Hello, I'm Dr. Goel. How are you feeling today?
Good, doctor. Waiting to hear.
So, doctor, what news?
We need to discuss the situation in detail. Would you prefer to do it now or when we are alone?
Now is fine, doctor, and I would prefer Varsha to be here.
Okay. Come, Varsha. Let's sit. So, before I start, let me ask you, how far do you know about your condition?
I know it could be serious, and it depends on my blood work report.
See, I could go into the details, but some patients want to hear just general picture. What would you like to hear?
I think the general picture, doctor.
Okay, I'll be frank. The tests are not looking so good, and we have to start some aggressive treatment. That means some side effects. Sorry for the interruption. Would you like me to continue?
I don't know if he should be here.
No, I want to hear this. I need to.
Okay, I wish I could give you some good news. But the blood count is much below the normal level. Let me tell you the present condition, what the exact condition is. It is not so easy to handle the situation, and we have to control it by aggressive treatment.
Okay, so in conclusion, breaking bad news is difficult, but it's very important to do it properly. Effective communication is essential to ensure the patient understands what is happening fully. The spikes method is a simple approach to follow, and it helps us to ensure that bad news is discussed in the best possible way and to ensure you maintain a bio, psychosocial, spiritual approach to ensure holistic care. Thank you.
Thank you. Thank you to Ernest and the team. Well done. Generally, we get really very good presentations, and thank you for doing that. Thank you to both teams for doing that. So let's just get any comments or questions from anybody, and comments from Dr. Aki Petkova, if there's anything to add. Gisela, go ahead.
Hello. I
Yes.
wanted to ask the team, I've had a lot of experience breaking bad news with cancers and the like, and I've found that patients are usually not interested in discussing what they already know. They just want the diagnosis and they want to talk about it afterwards. How do you go about that then? Do you tell them what they want to know without like leading into the conversation, or is there another way to do that?
I don't think that one would want to have them say, to spend a lot of time. But I do think that even if they seem resistant to tell you more, I mean, unless you have a relationship where you've shared things with them, but even in that situation, you'd want them to say, well, just give me a quick understanding of what you think is going on. And that is very helpful. And it doesn't need to be long. So, Gisela, I think it's about easing your way into the challenge of sharing that information just off immediately. And Gisela, I'm not sure in your setting whether you perhaps have a relationship. If you've met the patient before, then you've already begun that process, in which case, you know the patient better and you could perhaps share the information. But I think that understand that that you don't want to just come splat with bad news immediately. You want to ease into it. It doesn't need to take very long, but don't just say, sorry, he's got cancer, and that's boom, when you've just been asked to talk to the patient. Gisela, does that make sense?
Yes, it does. Thank you.
Yeah, it doesn't need to be a long-winded, tell me about it and get them to explain 100 things about it. It's just interrupt their minds and then ease into the discussion. I think asking them particularly, what do you think is going on? Helps them to share their concerns, what their ideas are and what they're worried about. And then to say, yes, you may be correct. It gives you the context to do that warning shot. And then, tell them, well, the results. Where do you want me to take the results? Where do you want me to share the details as you feel it is? So, Dr. Vitkova?
Thank you, Prof. I just wanted to say that in this video, maybe the interns can point out what was the mistakes the doctor made during the meeting of the patient and the family member of the patient. And
in the
also,
first video? No, the second.
The second one, the last one. And also, when you break a bad news, depends what is the situation. You have to decide whether to start with the introduction, with the how much the patient knows. Depends what kind of bad news you're breaking. You need to decide how to do your process. So you need to be aware what exactly you're doing and how to structure the whole thing, not to fail in front of the patient, because the families, especially when it comes about the death of the patient, and you have to speak to the family, you have to be very much motivated when you go and do the breaking of bad news, because failing to do that, it's the family can judge you badly. Thank you.
Thanks, Dr. Petkova. I think an important principle that was intimated, but it's really important, is for you, and the two things. One is to get rid of our own God complexes, as was said by Ernest right at the beginning, that we see failure. That failure is something that's of our own construct, because we think that somehow we are somehow gods, that we can get everybody ill, that and heal everybody. And I think that's our own problem. We need to get rid of that. We need to understand our limits, and we need to acknowledge that. So when you enter into any conversation, generally, even if it is, sharing results, minor results, I think the idea is not to see ourselves as responsible for the person's outcome. You've got another patient 15 minutes later, etc. You've got other people to deal with. You can't let, your idea that I have to solve every problem, knock yourself. So that's one important thing. It comes especially in handy when you're dealing with bad news. But the second thing is that you need to prepare yourself when you are sitting down with the patient. And to me, it's about that short preparation where it can take very few minutes, but it's just the way in which you move along. You don't need to have a long-winded process. And to me, that's important. And I think one of the key problems also that is important is the one of giving information. Patients are the priority. You cannot talk to family and not to the patient. You can have the patient saying which of the family they want. And as you're going along, if you see that there are difficult family members, you can ask the patient, you want us to break out into a room with you only? How would you like to continue? So I think the challenges in that setting, you need to always be in a control. Don't let things spiral out of control. But never keep away information that's relevant for the patient to make decisions. So I think that getting the patient to help you decide information is a very useful point that the Spikes model has. So good thing, good sort of model. I appreciate that. Jimmy, do you want to add, or Dr. Petkova, Dr. Aki, Dr. Petkova? And if there are any questions, please feel free to pick up your hand. Dr. Aki?
Yes, Prof. I think you've pretty much covered everything. However, we need to appreciate how difficult it is. The most important thing is you need to make sure that your encounter with the patient, you've created that rapport and that trust in the first place, that you are genuine and honest about everything you discuss with the patient. You will find it a lot easier to break bad news to somebody you've become close to. And the way you speak to them, the way you discuss with them issues from the beginning will determine how easy or how difficult it will be to break the bad news should it come. In that vein, the issue of family members or friends or whatsoever, I think you need to also establish that during the process of interaction with the patient earlier on, before any of those issues arise, to establish who are the confidants in the patient's life, how do they relate, and what are some of the common things that they share, how close to these people are they, and who do they usually hang around with, and who do they usually confide into. So it might give you an idea of the way you are going to handle breaking bad news in the first place. And it makes your life a lot easier when you know some of these things up front. Thank you, Prof.
Thank you. I think all these models that are presented, I think the tendency amongst us as young doctors would be to say, that's going to take a long time. And please don't be under that illusion. When you sit and practice them, you're going to find yourself taking a little long. But once you get the hang of it, you're going to assimilate it into your own model of engaging with patients, with sort of adapting it to context. So please do not dismiss these as theoretical and impractical. You've got to put it into practice, and then you'll see that it can happen very easily, very quickly, and you'll develop the kind of skills that set you apart. So please think about this. These are, that's the problem with some of these family medicine skills, that we think that it's necessarily long discussions. It's not. It's short skills that you can include into your everyday consultations. Any questions, comments? The only way you can get this right is practice, so we're going to have to look at another time. I'm just not in the mood right now because people are supposed to do things and they didn't quite do it. So I think please, in the case presentations that you're going to get, case discussions like next week, we will have a chance, maybe we can include it where we do small consultations and show you how it can be done, okay? But please do not waste our time by not looking at these cases, not revising and reviewing the work that was presented today, and making the first hour a little meaningless. So please do spend some time. We are spending our time with you to give you teaching, and it is not very encouraging to us when you don't do what we expect you to do. All right. Okay, if there are no comments, we'll conclude today a little earlier and see you all next week. Please do, as I said, read the presentations and the case presentations as well. So to the groups that are presenting next week, please send out your presentations by Monday at least. To the groups that have presented today, share the presentations and the cases on the WhatsApp group so everybody has it and can prepare for next week.